Before starting our case, we need to talk about the bronchosegmental anatomy to the left upper lobe. As you know, the left upper lobe first segment to be seen in CT cuts is the apico-posterior segment. The apico-posterior segment are one segment on the left side, okay? And when you go down, the segment will start to appear here as the anterior segment. So whenever you see the trachea, the lung segments seen here are of the left upper lobe. Okay, when the trachea bifurcates, the left upper lobe and the left lower lobe segments will be seen. Okay, so here I can see the trachea. So this is the anterior segment, and this is the apico-posterior segment of the left upper lobe only. Okay, when the trachea bifurcate, this is the left upper lobe segment, and here this is the left lower lobe segment. Okay, so when the trachea bifurcate, I can see that upper and lower lobe segments. The upper lobe segment seen here is the anterior and the apico-posterior. The lower lobe segment seen here is the apical segment of the left lower lobe. Let's talk about the bronchosegmental anatomy. The trachea will bifurcate into two main stem bronchi. The left main stem bronchus first branch to the left upper lobe. So the left main stem bronchus first branch is the left upper lobe bronchus. Okay, left upper lobe bronchus. Okay, the left upper lobe bronchus can't be seen on CT cuts because it runs vertically, so it can't be seen. It can't be seen as it originates from the left main stem bronchus. However, their branches will be seen, as you can see here. So the left upper lobe bronchus can be seen, however, their branches are seen. The branches are the anterior segmental bronchus and the apico-posterior segmental bronchi. Apico-posterior segmental bronchi, okay? As you know, the left upper lobe segments are four segments, okay? We've mentioned the apico-posterior and the anterior segments, and now the other two segments are the inferior lingular segment and the superior lingular segment. Now let's talk about the bronchosegmental branches, of the left main stem bronchus. So as you can see here, this is the left main stem bronchus, okay? Then it will bifurcate into left upper lobe bronchus and left lower lobe bronchus. Now this is the left main stem bronchus, bifurcates into left lower lobe and left upper lobe, okay? The left upper lobe bronchus will bifurcate into superior division to give segmental branches to the superior segments of the left upper lobe, and the inferior division will give the segmental branches to the inferior segments, which are the lingular segments. So this is the left upper lobe bronchus, and now it gives the superior division. This is the superior division. The superior division, okay, gives segmental branches to the superior segments, apico-posterior and the anterior segments. Now, this is the inferior division, okay? These are the segmental branches from the inferior division of the left upper lobe bronchus. The inferior division will give segmental branches to the inferior segments of the left upper lobe. Superior lingular segmental bronchi, inferior lingular segmental bronchi. Now let's start our case. 55-year-old smoker with breathlessness. Okay, so this is a chest x-ray. The chest x-ray showing this. Can you see this? There is narrowing of the left main stem bronchus. This is the right main stem bronchus. However, this is the left. Can you see the narrowing of the left main stem bronchus here? Narrowing of the left main stem bronchus by this. Can you see this? And increased density around, projected around the left hilum, causing narrowing of the left main stem bronchus. Okay, with the resultant V-like opacity of the left hemithorax. V-like opacity of the left hemithorax, denoting left upper lobe collapse. Why? Because there is narrowing of the left main stem bronchus with the resultant compression and occlusion of the left upper lobe bronchus. As I mentioned, the left upper lobe bronchus is directing vertically, okay? However, the left lower lobe bronchus will be directed horizontally, okay? So there is occlusion of the left upper lobe bronchus with collapse of the left upper lobe. As you know, the left upper lobe bronchus gives 4 segmental branches to the 4 segments of the left upper lobe: apicoposterior, anterior, superior lingular, inferior lingular. That's why left upper lobe collapse will be seen as a veil-like opacity of the left hemithorax. Okay? So we need to talk more about the left upper lobe collapse. Signs on chest x-ray. This is an example. A veil-like opacification of the left hemithorax, okay, with this sign. Crescent-shaped lucency representing air within the left lower lobe. Air within the left lower lobe, situated between the thoracic aorta and the collapsed left upper lobe. This is called left Seychelles sign. Okay, left Seychelles sign indicating compensatory hyperinflation of the left lower lobe as a result of collapsed left upper lobe. So the left lower lobe will try to compensate, okay? And the air within the hyperinflated left lower lobe will be seen situated between the collapsed left upper lobe and the thoracic aorta, giving the left Seychelles sign. Left Seychelles sign can't be detected here because of these opacities projected around the left hilum. However, the veil-like opacification of the left hemithorax is seen here. Okay. Also, there is widening. Can you see this? There is widening of the right paratracheal stripe. I think the widening involves both paratracheal stripes, right and left paratracheal stripes. Okay, I will show you this here. This is the normal. Can you see this? This is the normal right paratracheal stripe. So if you go with the trachea, okay, start to look for the paratracheal stripe from the level of the clavicle, okay? So from the level of the clavicle, try to detect the paratracheal stripe like this. This is the normal right paratracheal stripe, okay? Also, this is the left paratracheal stripe, okay? Starting from the level of the clavicle. So compare this with now here. Can you see this? There is widening of the right paratracheal stripe starting from the level of the clavicle. Yeah, widening. And also here, can you see this opacity? Yes, widening here and here. So there is also widening of the right paratracheal stripe, which may indicate enlarged lymph node. Okay, enlarged lymph node. If you look carefully, you can see bilateral nodular opacities. Nodular, nodular, nodular opacities. All of these are nodular opacities. All of these. Also here, nodular, 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 nodular opacity. Can you see this and this? All of these are nodular opacities. So there is bilateral nodular opacities along with reticular opacities. Reticular opacities. Can you see these linear opacities? This pattern is called bilateral reticulonodular opacities. Reticular opacities is seen also here. So there is bilateral reticulonodular opacities. Bilateral reticulonodular opacities along with suspected lung malignancy. This may be what? Lymphangitis carcinomatosis. Reticulonodular opacities. Okay. So what about the ribs? If you look carefully, this is the second left rib, the third, fourth left rib, fifth. What about the sixth left rib? I can't see the sixth left rib. This is the seventh left rib. The sixth left rib, I can't see it. Okay, this is the seventh, the eighth, ninth. Okay, however, here I can detect the sixth left rib, posterior aspect of sixth left rib. Okay, so absence of the left sixth rib posteriorly. Okay, and if you look here into the abdominal x-ray of the same patient, you need to look carefully for the pedicles of the lumbar spine. The pedicles of the lumbar spine. Can you detect the absent pedicle here? This one. Okay, this is L1. Left pedicle is absent. Absent left pedicle of L1. Absent left pedicle of L1. Okay, this is very important sign. Okay, this is a previous case I've mentioned before. So can you see this? This is a normal pedicle, All of these are normal pedicles, okay? However, here you can see the margins. You can see the margins of the pedicle, okay? So, can you see this? There is an adjacent lytic lesion, okay? The lytic lesion is also destructing the left pedicle, okay? So here, there is L1 lytic lesion destructing the left pedicle, okay? This is a diagnostic sign of destructive lytic lesion or vertebral metastasis, okay? So this sign indicates a vertebral metastasis. So the interpretation here, this patient has left hilar increased density, causing narrowing of the left main stem bronchi and collapse of the left upper lobe, along with this patient history of smoking. This hilar density is most likely to be a primary lung malignancy with contralateral mediastinal lymph node involvement, seen as widening of the right paratracheal stripe, and also with bilateral lung metastasis in the form of lymphangitis carcinomatosis, seen as bilateral reticulonodular opasitis, with ipsilateral bony metastasis, seen as absent left 6 rib posteriorly, and also with vertebral metastasis, seen as absent left pedicle of L1. So we have here 2 bony metastases, okay? So the diagnosis here is primary lung cancer with bilateral pulmonary as well as nodal and bony metastasis. The differential diagnosis here, all of these lesions are metastatic deposits from a primary tumor that's not in the lung. The primary tumor is elsewhere in the body, okay? The management here for this patient needs more pathological investigations, okay? This patient needs, this hilar mass needs to be biopsied, okay? Maybe by bronchoscopic guided biopsy, okay? So this patient needs image-guided biopsy for tissue diagnosis, maybe by bronchoscopic guided biopsy of the hilar mass. This patient also needs more radiological investigations. He needs pre-treatment assessment of the stage of the lung cancer. Pre-treatment stage assessment of the lung cancer by CT scan of the chest, abdomen, and pelvis, okay? This patient also needs urgent referral to the chest clinic, and I would recommend discussion at lung cancer MDT. That's all for this case.